50 minutes with. Today, it's a pleasure to have with us Dr. Stefano Galli. He's an interventional cardiologist of Invasive Cardiological Unit 2 of Cardio Hospital Monzino in Milan. He's an expert in high-tech in cardio imaging such IVUS and OCT. We want to know your opinion on full imaging guided PCI in the vulnerable patient. Before to go in depth, let me ask, who is the vulnerable patient?
So thanks a lot for this invitation and the opportunity to describe the vulnerable patient. At the moment today, we know that the vulnerable patient is the patient that high risk to adverse event, cardiac death, myocardial infarction, urgent coronary vascularization. And at the moment, it's not so easy to identify the patient before the event. We know very well that the ischemia drive this revascularization, and we stratify our intervention on basis if the patient have or don't have ischemia. But this is a new paradigm. Identify in advance the vulnerable lesion in a vulnerable patient and decide how to do. I believe that the vulnerable patient is the diabetic patient with a lot of coronary high risk factors, and finally, probably the most high risk patient is the patient with acute coronary syndrome. And in this patient, the vulnerable lesion is more frequent and present.
So it's a high risk patient to manage. What is your objective in such patient? How do you manage a vulnerable patient?
So today we have in invasive strategy, we have an angiogram. But the angiogram is a lot of limit to identify the vulnerable lesion. We have a second level invasive strategy, IVUS, intravascular ultrasound, that is able to identify plaque burden, able to identify the minimum luminare, but it's not difficult to identify the other vulnerable characteristic. OCT, on the other hand, is not so easy to identify the plaque burden, but it's easy to identify the minimum luminare and also the other high-risk characteristic, calcific nodule, macrophages, soft plaque, ulceration, erosion, and so. But it's not easy for the for a lot of physicians identify. We have the IVUS and the new technology, near infrared spectroscopy, is a tool combining together with IVUS, is able to identify the vulnerable plaque. So this technology is a chemogram that identify with a color code, in this case yellow if we have a lot of soft lipid plaque, and the red if the level of lipid or soft plaque is very low. The lipid core burden index is a value of a amount of lipid into the lesion, and if the level is more than 350, it is a standard cutoff that was accepted by literature. So this is identify the high-risk plaque. So in 2 words, NIRS is able to identify soft plaque or not soft plaque and quantify the level of soft plaque.
So, in such patients, international guidelines recommend full imaging guide PCI. What is the role of morphological investigation of coronary lesions, mainly done with combining NIRS and IVUS?
So this is a very interesting question, because today the guideline move, especially the task force document of imaging, IVUS and OCT, move a lot interventional cardiology to use a second level imaging, IVUS or OCT, to guide procedure. Obviously, as told before, the information regarding IVUS and OCT is very lot, but NIRS could apply another type of information, the vulnerable plaque, and I believe that is another step in our knowledge to treat. So not only the lesion is tight lesion or very calcified lesion or thrombus, nor thrombus, or ISR, non-ISR, subexpansion stent, subexpansion stent, but also in not so critical lesion in terms of narrowing, but critical or severe in terms of morphology, and NIRS help us a lot in this view.
Would you explain what are the benefits for interventional cardiologists and for patients?
So, to answer to this question, I use a recent study published by Lancet, the trial. This Prospect 2 trial analyzed the patient with acute coronary syndrome that was fixed and treat the culprit lesion. But in this situation, investigator analyze and identify the other intermediate lesion. Especially this in this paper, it's very important because all lesions were assessed by functional evaluation, FFR. If was FFR positive, obviously were treated. If not, were investigated also with IVUS NIRS, and were classified on basis on high risk or not high risk. In other words, identify plaque burden more or less 70%, mean lumen area more or less 4.0 millimeters square, and NIRS characterization more or less 350 LCBI. So and the patient and subgroup of patients were treated with absorbed stent, but this is another thing. At this moment, and it's very important discuss that the patient after 2.5 years mean follow-up were analyzed, and this cohort of patients, in 13% of the cases, these patients have major cardiac events at follow-up. But very interesting, 80% only from not culprit lesion. In other words, not lesions were treated during target procedure, which is the characteristic of this patient. And this lesion is lesion with plaque burden more than 70%, minimum lumen area less than 4 millimeters, but mainly the event are more frequent in patients with high risk vulnerable plaque by NIRS with LCBI more than 300. In other words, this study demonstrates that the lesion with this characteristic also is not critical, is not are a very critical lesion, but only for the morphology, the vulnerable morphology, are lesions that are more risk into the future. For this reason, I believe that this study support the necessity and the opportunity, in other words, to use this technology to identify this lesion, because impact a lot in terms of event into the future.
So those are the clinical evidence, but what is your experience in detection, management, and treatment of vulnerable patients combining NIRS and IVUS together, and why should be implemented by cath lab such approach?
So in force of this evidence and this result and the necessity to identify the lesion not only in terms of ischemia yes or ischemia no, but in subgroup of patient, the necessity, the need to identify the culprit vulnerable lesion is crucial. For this reason, in my lab, we start with NIRS program, with IVUS NIRS program, in the a subgroup of patients. First of all, the patient that were undergoing to CT scan, where we identify not critical lesion, but soft plaque. These patients were stratified with IVUS NIRS to check and to verify these characteristics, especially in the proximal part of the lesion, because in this region of the coronary, for example, proximal LAD impact a lot on the prognosis. Another group is the patient with a lot of risk factor, especially in the young man. And third, and the big field of investigation is the acute coronary patient, ST elevation or OST elevation, the lesion, not culprit lesion. So in this patient, with culprit lesion, for example, in RCA, and the lesion also is moderate lesion in LAD, the proportion of vulnerable plaque, not critical, in this patient is high. And I believe that it's very important to investigate, to assess. Obviously, the big question is how to treat this vulnerable plaque, and probably this is a matter for the future, for the other investigation. At the moment, I believe that we have no evidence that all lesion, all vulnerable lesion we are stented. Probably, I believe the combination of optical medical therapy, LDL less than 50, and stent only the focal, very focal lesion. But this is my opinion. Probably we need a lot of study. But the first point is identify the vulnerable plaque, and I believe that the NIRS is a big tool to this scope.
Okay, Dr. Galli, thank you so much for your time and for sharing your experience with us.
Thank you a lot for your invitation. Bye-bye.
Bye.